Tumor lysis syndrome is a condition which occurs when a large number of cancer cells die within a short period, releasing their contents into the blood. Cancer cells are destroyed by chemotherapy, but their contents are released into the bloodstream where they accumulate. These include nucleic acids, purines and pyrimidines, which make up DNA, potassium, which results in hyperkalemia, phosphate, causing hyperphosphatemia, which in turn causes hypocalcemia. Let's take a closer look. The main cation present in cells, including cancer cells, is potassium, and the main anion is phosphate. The DNA present within the nucleus of our body cells or cancer cells consists of purines and pyrimidines. Both of these are broken down into metabolites by intricate pathways in the body. We'll focus on purine nucleic acids, which are broken down to hypoxanthine, which is further converted to xanthine, and finally uric acid, with the help of the enzyme xanthine oxidase. In tumor lysis syndrome, due to increased DNA and purines present in the bloodstream from destroyed cancer cells, increased metabolism of purines causes increased production of uric acid. This leads to hyperuricemia, and the uric acid deposits in the kidneys in the form of urate crystals, causing acute kidney injury. In tumor lysis syndrome, phosphate is also released in large amounts from cancer cells. Phosphate in the blood is bound by free calcium, which reduces the calcium levels in the blood. The resulting hypocalcemia can manifest as numbness, tingling, tetany, and seizures. Potassium released by cancer cells leads to hyperkalemia, which can cause arrhythmias. Tumor lysis syndrome can occur spontaneously on the start of treatment or even a few weeks into the treatment course. However, not all cancers can result in tumor lysis syndrome. Risk factors include large tumors and rapidly dividing tumors such as acute leukemias and high-grade lymphomas. What actually triggers tumor lysis syndrome is usually chemotherapy, but it can also occur due to radiation therapy, hormonal therapy, or steroids. To diagnose tumor lysis syndrome, the Cairo-Bishop definition is used. It divides the tumor lysis syndrome into two types: laboratory and clinical. In order to diagnose laboratory tumor lysis syndrome, two or more of the following must be detected: increased uric acid levels of greater than or equal to 8 mg per deciliter, increased potassium levels of greater than or equal to 6 milliequivalents per liter, increased phosphate levels of greater than or equal to 4.5 mg per deciliter, and low calcium levels of less than or equal to 7 mg per deciliter. Alternatively, any values 25% greater than the baseline are also accepted. To diagnose clinical tumor lysis syndrome, the laboratory diagnosis along with one or more of the following is required: creatinine levels that are 1.5 times the upper limit, cardiac dysrhythmias or sudden death, or seizures. Management of tumor lysis syndrome is mainly prophylactic. Intravenous hydration can be done for at-risk patients to up to 3 liters in 24 hours. Allopurinol is also used prophylactically 24 hours before the start of chemotherapy. Allopurinol inhibits the enzyme xanthine oxidase, decreasing the production of uric acid. Rasburicase is also used similarly, but only in very high-risk patients. Rasburicase catalyzes the conversion of uric acid into allantoin, a water-soluble product that is excreted into the urine. In patients with tumor lysis syndrome, hemodialysis may also be done to correct the electrolyte imbalances in order to prevent damage to the kidneys, heart, and brain. With that, we complete the topic of this video, tumor lysis syndrome, where we've discussed its pathophysiology, onset, risk factors, causes, diagnosis, and management. On my next video, we'll go through the common complications associated with chemotherapy. Until then, I hope to see you again on sqadia.com.